when we talk about therapy is just treatment, which I know you are aware of, okay? It's
Mm-hmm.
just treatment. So being a treatment, when we say cell treatment or cellular treatment, we're talking about using cell to cure disease, using cell to treat disease. Do you understand me? Okay. So, and that is where if you are to bring it to the basic blood bank, I said if you give somebody red cell, that is, if someone is anemic and you give the person red blood cell, that is cellular therapy.
Mm-hmm.
You understand me? Okay.
Mm-hmm.
If someone has leukocyte, low leukocyte, and you give the person leukocyte, that is therapy. If someone has low platelet and you give the person platelet, that is therapy. So in cell therapy, we are talking about using cell or tissue, like you said, to do that. Do you understand me? Okay. So now in this cellular therapy, please, I want you to, anywhere you mix me, just let me know. In these cellular therapies, because we are using cell for treatment, okay, remember before today we had discussed about cryopreservation, right?
Yes.
Good. So which I'm sure I'm going to ask you that question later, but hopefully you've looked at that. So now, in what exactly are we preserving? Is these cells? Are you getting me? And like what you said, the cells we are preserving are not the common cells. In this kind of preservation of a high, low temperature level of -130, as the case may be, is not for red blood cell. Does that make sense now? Okay. So if for some of the cells that are not very rare, that are very rare. So those are the ones that we try to preserve. So what am I trying to say? In cell therapy, then you look at stem cell therapy, okay? Then you look at gene therapy. Now, remember, in gene therapy, I think, depending on where maybe someone DNA can be isolated and all of that, as the case may be. So you look at gene therapy. Now, you now look at adoptive cell transfer. So what do I necessarily mean by adoptive cell transfer? That is where you can see that in cell therapy, the common word is CART cell therapy, CART cell therapy, okay? So the C talks about chimeric, is a type of antigen. Chimeric, and A talks about antigen, and arrow talk about receptor. Now T talk about T cells. Does that make sense now? So in CAR T cell therapy, T cell is a lymphocyte, basically. Do you understand me? Okay. So that is not treating someone with T lymphocyte, as the case may be. Now, so I've mentioned stem cell therapy, gene therapy, adoptive cell transfer therapy, where this CAR cell therapy comes in. So now maybe I should explain why it is adoptive. Okay. So what happened then when we use CAT, just in case it should be one of the common things that they do in this lab you are going to go. So when you talk about CAT therapy or CAT cell, so what you are doing is that you are using a T cell, okay, and that T cell can be, how will I put it now, can be manipulated. So in that manipulation, to now be specific to this chimeric, because it acts as, remember, is a receptor antigen, like with the CAR, CAR is a receptor. So receptor means that it can be specific to a particular antigen. Do you understand me? Okay. So what it means that with this CAR, then they can manipulate the T cell to be specific to this CAR, which is chimeric antigen receptor. Are you getting me? And that specificity help it to, manipulate the T cell to be able to attack a particular thing that they want it to attack. Does that make sense? Okay. Now, having known this, then what it means that in cell therapy there are two main types of cellular therapy. There are two main types. Number one is what we call autologous therapy or allogenic therapy. Now, remember that in autologous therapy is like you obtain the cell from the same patient. Okay, so when you obtain the cell from the same patient, because there is something you want to get rid of, that's why that CAT comes in. Okay, so you can obtain the T cell, for example, from a patient, and that T cell you're going to obtain from the patient, you can manipulate the T cell of that patient with the help of this very chimeric antigen receptor to attack a particular thing that you want it to attack. Does that make sense? Okay, so let's say in terms of maybe cancer cells, as the case maybe, it can attack it, try to mop it up and get rid of them. Okay, but once that type of therapy is obtained, is manipulated using the patient's own cells, are you getting me? Okay, to do the manipulation, and following the manipulation of that patient's cell, you now give it back to the patient. Are you getting me? That is called autologous type of cellular therapy. Okay, opposite of that autologous is allogenic cellular therapy, okay? Again, which is a common one that is more abundant, where we can use a donor T cell, so a donor cells, okay, to manipulate the donor cells to be able to help the patient. Do you understand me? So when we do the treatment, if there is any cellular treatment that involves donation by an individual, which cannot be used to treat a patient, that is then called allogenic. Does that make sense? Okay.
Yeah.
Good. Now, another way you can look at this, which depends on how you look at it, if you look at auto, it's just like the way you say auto. Once you say auto, it means self, like when you say auto antibodies. Are you getting me? Okay. Now, if you remember when we say allo antibody, it means acquired because it's coming from outside. Okay. It's as a result of exposure of foreign antigen. Do you understand?
Yeah.
Okay, good. Right. Now, why are we using this cellular? Why is this cellular therapy important? There has to be a dysfunction. There has to be something that is not working very well, and that thing that is not working very well may require repair. It may need to be replaced, okay? Or maybe the thing is there, but it's not functioning very well. The function of that very cellular or whatever, as the case may be, may need to be enhanced. Its function may need to be enhanced. So either to repair or replace or to enhance cellular function, okay? That is the whole essence of cell therapy, okay? And that is why this can be commonly seen in cancer, autoimmune, okay, disease, and of course degenerative diseases. Does that make sense?
Yeah.
Right. So having explained that, then, so when we come to autologous and allogenic antibodies, so you already know the treatment, you already know the difference. Now, I'm saying this because in case you go for interview, they ask you what is the difference between autologous and allogenic cellular therapy. We've already explained it. So in autologous, it means that it's a patient own cell that you're using for treatment, okay? So now, if we're using the patient own cell for treatment, what do you think is important compared with that of the allogenic? It will reduce the risk of immune rejection or maybe immune reaction, okay? It's going to reduce that risk, okay? And again, cell need to be, of course, with that as well, you need to then have to collect the cells and then process the cells, okay? And then before giving it back to the patient, okay? Now, unlike the allogenic that comes from the donor, okay? So it's the donor type of cell treatment. Now, the risk factor obviously is like your graft versus host disease because, there can be incompatibility and all of that. So because there can be incompatibility and the possibility of the risk of the immune reaction and all of that. So when it comes to allogenic type of cellular treatment, what do we need to do before using that treatment, before exposing patient to that cell? Basically, because there's a possibility that it may not be compatible. So we need to compatibility, okay? So that means it will require cross-matching or matching as the case may be. Do you understand me? Okay. So even if you want whatever you want to, even if it is bone marrow transplant, you must do matching to make sure. Are you getting me? That was why, if you remember when I was teaching you guys in blood bank, I mentioned about human leukocytic antigen matching. That's match. So what it means is that we want to give somebody a cell, white cells, okay? We want to give somebody T cells or whatever as the case may be. We need to match that the patient's cells, even though the compatibility may not be absolute, but we want to make sure that the differences will not cause, adverse effect. And we're going to now look at the challenges in this cellular therapy. So obviously there is obvious one, which is immune reaction, okay? Yeah. Especially when you are looking at that allogenic. So that's immune reaction. So what it means that we now need to find a way to manage the risk of what? Immune reaction or immune rejection or graft versus host disease. Do you understand me? So now, in this cellular therapy, unlike every other type of therapy anyway, but we're focusing on cellular therapy. So we've mentioned that one of the challenges is immune reaction. We need to manage the risk of that or, and to prevent graft versus host disease. What are the other things that are very, very important in this aspect of therapy or aspect of pathology lab? In this cellular therapy, like every other blood bank, every other pathology laboratory, you consider the quality. That thing you are giving to somebody, you need to make sure that it maintains quality. Do you understand me? Okay. And because we have said that even if it is own cell, even if it is donor cells, those cells need to be collected, it need to be processed before it can be used, right? What it then means is that we need to make sure that both the manufacturing and the quality of that thing is well regulated. Do you understand me? To make sure that it maintains the required standard. Are you following me? So the manufacturing process needs to adhere to the rules and regulation, okay? And of course, that will now lead to making sure, of course, there has to be quality control as well. These two now can now ensure that the quality of the product you are giving has maintained standard. Okay, so manufacturing and quality control, very, very important. Now, what it then means is that this would then help to look at increase the efficacy and of course the safety of that very product, meaning that the product will be viable and good for the patient, and of course it will be safe for the patient to have it. Okay, now but even though we have processed it and it is safe to have it, remember we're talking about the challenges. So we've looked at the immune reaction, managing it. So that because it's a challenge doesn't mean that we can't go and do what we want to do. We just need to manage the challenge. So in managing the differences in the to ensure there's not going to be any immune responses or rejection of immune system, what do? We do the matching, right? Okay, that is one of handle to overcome that challenge. Another way to be able to overcome the challenge, because the challenges mean that because of these differences of different people and all of that, we now need to regulate the manufacturing and the quality control as well. Okay, now obviously, because we want to ensure that there is efficacy and safety in what we are doing, which is where the manufacturing process and quality control comes in, we now need to continue even after someone has had that thing. You have transfused the person, you have treated the person, you don't stop. You want to find out this thing I have given this person, has he benefited this person? Do you understand? Okay, so you can now look at the long-term outcome and maybe potential side effect. Does he have any side effect or long-term outcome? Do you understand me? Okay.
Yeah.
Now, another challenge is obviously, which is the main one as well, is the regulatory issue. So there are a lot of regulatory bodies that are involved, isn't it? Okay, so you now need to find a way to make sure that the regulatory bodies, all the regulatory bodies involved in cellular therapy, that you adhere to their requirements. So navigating complex regulatory pathways. Does that make sense? If we are going to collect the samples and process the cells, there has to be in cell therapy, there has to be collection, okay, there has to be processing, and there has to be expansion, and then of course we've mentioned cryopreservation and then quality control. Now let me start all over. So handle and processing cells for therapy. One, to handle them, we have to collect it first. So what it means that we need to collect the leukocytes, okay, or we can get a bone marrow aspirate. So do you know what is leukapheresis? When you hear the word pheresis, I mentioned it when I was teaching you guys. Do you know what it means? Apheresis is from one person. While when you say pool plasma or pool platelet, that is not apheresis. Apheresis means from one donor. Remember, in this type of treatment, you can be getting different bone marrow. Are you getting it? It has to be from one donor. Everything we're doing in this type of cellular treatment, it has to be apheresis. Okay, so leukapheresis and bone marrow aspiration, we need to collect it. Okay, then we can process it. What it means, we'll isolate whatever thing we're looking for, purify the cells. So in processing, we isolate the cells, we purify the cells, and we can decide to expand the cells depending what we want. Okay, maybe if it is leukocyte we're interested on, we can actually culture that leukocyte. When we culture the leukocyte, what is going to happen? The leukocyte will multiply, isn't it? Okay, so as it multiplies, it can now expand that very leukocyte. From one donor, you can now have many of that very cells. Okay, now of course we've mentioned cryopreservation, where we can now decide to store this, this product for a very long time. Okay. Now, when you talk, then the next thing will now lead us to quality control. So in quality control, you now need to first of all test to confirm that the cells meet the safety, okay, and efficacy standard. Do you understand the point? Okay. So it's not because of there's a donor. We have to do the test. That's what I'm trying to tell you. You can't just give cellular therapy. You need to make sure that the cell, has maintained standard, is potent, is efficacy, whatever as the case may be. So once you are sure that it maintains standard, then you can now collect it. Do you understand me? And store. Now, when somebody is in need of such treatment, the problem we now have is this one we have in stock, is it compatible with this person? Do you understand the point? So when antigen interacts with a receptor, okay, then it can activate inflammatory immune response. Okay. So now there has to be a lot of interactions for antigen to do a particular thing. So one of the things that help antigen to perform its function or to develop something is when it can be able to interact with its receptor proteins. Do you understand?
Okay.
So what I'm saying that by the time they use technology to modify this patient T cell, that modification will not cause the patient T cell. They will make it, is a technology, to now be able to express this chimeric antigen receptor. Meaning that it can be able to receive, that's why it's a receptor. It can be able to bind, interact with that. Do you understand me? Okay? So once that happens, what is going to happen? Because that interaction is to do something. Are you following the point? Okay? This is basic immunology. That interaction is to do something. Leave this. So if someone is exposed to microorganism, that microorganism will interact with the patient receptor proteins. Are you getting me? And that will send a signal that can lead to the both production of antibodies. Does that make sense now?
Yeah.
Good. So I'm saying that one day T cell, because what we are after, there is a particular antigen we want to get rid of in the patient. Are you getting what I'm trying to say? So, but that antigen we want to get rid of in the patient, because the patient is a disease, whatever condition the patient is going through, the patient system cannot fight it. But we want to get something from the patient system. Are you getting me? That can help now to in turn fight that thing. Do you understand the point? Good. Now remember, when you talk about adaptive immune system, they produce antibody. When they produce antibody, what do? Future exposure of that thing will make that antibody to go and bind the antigen.
Yeah.
So when we modify the patient T cell, it will make it to express this chimeric antigen receptor, and that expression can now give it its target to now specifically to go and target a particular antigen, maybe cancer antigen. Are you getting me? Okay.
Yeah.
Now, once it attacks that very cancer antigen, that the engineering T cells are then infused back into the patient. Are you following? So because it has attacked the antigen, okay, that attack then, now obviously I expect maybe antibody will be produced or whatever. Now it cannot be, it's just like a form of immunizing someone against something. Yeah, that's what I'm saying. So once you modify the patient T cells, it will now express the chimeric antigen receptor. That will now help it to increase its target to a specific cancer antigen, okay, cancer antigens. And that's modified T cell now, okay, what is going to do, we can now give it back to the patient, okay. And that, because we have given it back to the patient, remember that before we give it back to the patient, we've done an in vitro experiment.
Yeah.
So we have seen, okay, this is going to work. Then we now carry that thing and give it to the patient. Because that thing that has happened in vitro, we want it to happen in vivo.
In vivo.
Understand? So we can now give the thing, that modified antigen, T cells, that has now expressed these chimeric antigen receptors. We now give it back to the patient, and that will now make that thing to recognize that cancer cells. Are you getting me? And attack it. Did you get the point?
Yeah.
Okay. Modify the patient T cells, that will not help you to express chimeric antigen receptors, okay, and that will be specific to attack a particular cancer antigens, okay. Then we now give it back to the patient, and that will now help to recognize that antigen and attack it. Is that okay?
Yep.
Happy days. So now again, in doing this, obviously there has to be ethical standard in cellular therapy, okay. So remember, we're going to look at it in more detail. And remember, like in blood bank as well, there has to be a lot of this kind of thing. You would expect that commonly there has to be all kinds of regulation, isn't it? Okay.
Yeah.
We make sure that the standard is maintained. So it's important, like I've said before, we adhere to the regulations, okay. We adhere with the ethical consideration. So because it's a T cells, is a tissue, are you getting me? There has to be ethics around how it can be manufactured, how it can be given, and all of that. Does that make sense? Okay. More importantly, after you've adhered to the regulation, you have adhered to the ethical consideration. How do we know that you have done the two? We will know it by your documentation and reporting. So each of these very regulatory body has aspect they are unique, they are monitoring. Are you getting me? Your own is to adhere to it. Now there is aspect where we look at ethical consideration, and that is where I think HTA comes in. Then after we've looked at those regulations, how we can be able to prove that we have maintained the standard prescribed by those guidelines is by documentation and reporting. Okay? Good. In cellular therapy, how do you ensure there's a patient safety, and how do you monitor patient safety? Do you understand the point? Okay. Now, you now need to look at, like I've said before we give anything, we need to make sure that that thing is compatible to the patient, isn't it? There are a few things I've said before. When we are after the product, not the patient, is a two thing. When the donor comes, we are not after the patient. Not that we are not after the patient, but you understand what I'm trying to say. We are after this thing that the donor wants to donate. Is it what we can accept? Does it maintain standard? Is it safe? Are you getting me? Okay. So by the time we now confirm that it is safe, then we can collect it. After we've collected it, then the next phase now is patient need it. We now need to ask ourselves, okay, what we have, is it compatible with the patient? Does that make sense?
Yeah.
So now we can't say because we have A positive blood, someone is B positive, let's give the person, they are all blood. No, we have A positive blood in the stock, but this patient is now B positive. So what we have in the stock is not compatible for the patient, isn't it?
Yeah.
So the question is, how can we get B positive blood, something like that? Okay. So how do we ensure patient safety and monitor? One, you have to do, for you to be able to find out what is compatible for the patient, you need to do what? Pre-treatment screening. Not like giving somebody blood, you must do the person blood group before now, antibody screening, right? Okay. So you must do pre-treatment screening test. Okay. Now, of course, you have to now do one, even after if you've done it and everything is okay, you now need to give the person the product. And in giving the person the product, what do you also do? You don't stop. Remember that you've given someone cellular treatment does not mean you should stop. You have done your initial check and you see this is okay, take this cell, and you've done that cellular treatment. The next thing is to monitor, to make sure, I hope this thing I've given, are you getting me? It doesn't cause problem. Obviously, if it does cause problem, we now have to investigate it to see what causes, the root of the problem. So you do the monitoring. Now, of course, in doing the monitoring, if there's any reason for adverse effect or something like that, okay, you now need to make sure that you report any of the adverse, event that happens. Does that make sense? Okay.
Yeah.
And of course, if there is nothing like that, or even if there is something like that, you can also do, especially if there is something like adverse event that happens that you have reported, you can also consider long-term follow-up, okay, to make sure the patient is okay. So these are the 4 ways you can ensure patient safety and monitor in cellular therapy: pre-treatment screening, monitoring, adverse event reporting, and of course, long-term follow-up. Okay. What are the challenges that one can encounter in cellular therapy? So this challenge here, we can have issue with cell processing. There can be problem with processing the cells, right?
Yeah.
Now, you see why I said it's not far. Number 2, there can be unexpected patient reaction. That's immune response now, okay? Does that make sense? Okay? Now, how can we overcome these challenges? If we notice, if there is, for example, maybe whether it's issue with cell processing, that means the problem. Whether it is unexpected patient reaction, which is a problem, that means it needs to be investigated, isn't it? Okay. Now, what is the essence of investigating something? You investigate something to find the root cause of that problem, to find a better way that can be done, isn't it?
Yeah.
So implementing new protocol. So that can lead you to implement new protocol. Okay. Or you can use the word policy actually. Anyway, I'm just using a general word. You can use anything, okay? That can help you to find a better way of doing something, or maybe it can help to in finding a better way, maybe modify the policy, that that kind of thing, okay? Something like that. That's one of the ways to overcome it. And of course, you can collaborate with experts. So meaning that if you encounter any challenges, you can actually ask people that are higher than you. I'll give you an example. When I was working in an NHS hospital, there are some cases if I get, which is common with every other person working there as well. There are cases if I get, I will call the NHS BT. Do you understand what I mean now? The blood bank themselves, I'll call them and say, see this case, what do you guys think? So what am I doing at that point? I have a problem that I want a higher authority to help me to solve. That's collaboration. Do you understand me? Okay. How do you stay updated? That's what I was trying to tell you before. Okay. When I was talking about the innovation around this aspect like gene therapy.
Yeah.
So now, of course, conferences, workshop, journals that you read, and all of that. Let me say something here. If they ask you, I hope you know. Let me say it here. I hope you know that CPD, there are different types of CPD. Now, if they ask you the CPD, which CPD have you done recently, or which CPD have you done in within the last 12 months, as the case may be, you just finish academic CPD. I hope you know that.
Yeah.
So that's your master that you say, I just completed my master with me. I just finished academic CPD in hematology, whatever as the case may be. You can say, in addition to that, I've attended conferences and workshops. I've read some journals and all. In fact, this kind of interview is good if you can read few journals around these areas. Are you get what I'm trying to say? Okay. So that when they ask you a question, you can say, yes, I've been studying. In fact, a recent journal that I've read concerning this cellular therapy, it was a study done by, maybe you can mention the name of the person if you remember, or you can say that study was saying this, that. Do you understand me?
Yeah.
So these are the way you can be up to date. So they may not say, how do you stay up to date? They may say, which CPD have you done in the last 12 months? Or they may say, what is CPD? Whichever way it comes. GMP is good manufacturer practice, okay? So clean room. So when you now talk about clean room, you're not looking at the room. Okay, of course, it has to basically mean that it has been decontaminated, it has cleared from all kinds of things, which we're going to look at in detail. But it means that in this room, it ensures that it is safe, that the product you are looking at, the product you want to manufacture, you want to give to patients after manufacturing, that it is safe and sterile. It means that the environment is well clean and ensure that it is safe for the manufacturing of the product, so that the outcome of the product will be safe and sterile. Things like that in your own words, any way you want to put it. So cleaning room ensures safe and sterile of what products. That clean, who determines how clean that room should be?
The regulatory body.
Correct. So because I want to get your head into that. You get what I'm saying? So meaning that even if they ask you about the regulatory body, you can actually say, for example, and bring the clean room inside. Do you understand the point now? Okay.
Yeah.
So now, this very clean room, all of this, and so has to be within it has to be operated within the guidelines to minimize any form of contamination. So the guidelines are the regulatory bodies. So it has to be, the cleaning procedures has to be operated within the guidelines, and that operation will help to minimize contamination risk. Okay, it will help to protect the patient safety. Okay, and obviously, because that is done, it has to meet the regulatory standard.
Yeah.
And to meet the regulatory standard, it means that it has to be by maintaining strict environment control. We need to control the environment very well, okay? And of course, cleaning protocols and documentation. Remember, those regulatory, but remember, they are not there with you. How would they know you are doing it? Your documentation. Are you getting me? Your cleaning protocols and your documentation. How did you clean and all of that? How? They are the one that will give you the guidelines. So you need to have SOP of how. Are you getting me? Then you need to document when you do it, so that when they come, you say, this is my SOP of how, which is according to your guideline, and these are the example of how we're doing it. Does that make sense?
Yeah.
Right. So what if a clean room can contribute to the product quality, obviously, because if it is not clean, what then happens that product is contaminated. Okay. Now let's look at some examples. There are so many of them, but I try to pick few. Have you heard about the word high efficiency particulate air?
HEPA.
Yes, correct. So HEPA filters, do you understand me? Are the things that they recommend. Air changes per hour. So there are air changes per hours technology. There can be laminar airflow, autoclave, clean, and steam in place. Are you getting what I'm trying to say? So these are the examples. HEPA filter, air changes per hours, laminar flow, okay, autoclave, clean in place, and steam in place. Okay. Right, let's look at some regulatory body from what you sent to me. What is JACIE? JACIE. Joint Accreditation Committee Europe. That means it's the European aspect of the regulatory body. Does that make sense? What is ISCTI? International Society for Cell and Gene Therapy. We have EMBT. EMBT. European Society for Blood and Marrow Transplant. There is a reason why I put this together, but I'm going to tell you all of them. What are they doing generally? What are they doing to ensure high standard, right? Their role is to ensure high standard in clinical laboratory aspect of cellular therapy and hematopoietic stem cells. That's transplant. So when it comes to hematopoietic stem cell transplant, when it comes to maybe cellular therapy, these things, they come in place. And remember when I was talking to you about quality management system, because of their regulatory body, they have to have structure, right?
Yeah.
So that means all of them act as a framework for quality management. They have to put a structure in place of what you need to follow to ensure that the standard is maintained. So it can act as a framework for quality management, which ensures safety and compliance. Okay? So meaning that this regulatory body regulate the lab to ensure that the laboratory are within conformance, that the product are safe, and it involves a framework to ensure that happens. Is that okay? You can see their differences are in their names. Now, of course, another regulatory body is Human Tissue Authority, which is HTA. When it comes to the Human Tissue Authority, they are regulating the safety of the tissue. They are looking at the ethical consideration of in the use of that tissue. Okay, how is the tissue produced? Who uses it? Are you getting me? So they monitor it, okay, to make sure that how it's being used, and of course how is it being donated, of course, is safe and is according to the ethical guidelines. Does that make sense? Okay, and they regulate it when it comes to medical treatment, research, and education. Now, what are their primary roles? One, to regulate, they help in the regulation of the human tissue use. Okay. Two, they help to licensing and inspection. They give license, and of course, they also inspect the lab. Three, they also regulate the consent and ethical practices. Okay, meaning that they have a guideline on whether the patient is or whoever the donor has given consent, that kind of thing. Okay, and all these ethical practices. And of course, because of they've put these structures in place, what do you think will happen to the public? There will be confidence, okay, and it will appear transparency. It makes the public to feel like, okay, you guys are not taking advantage of what we are denoting. Are you get what I'm trying to say? Okay, so, and it will increase confidence, even the people who are donating and people who are using it, of course, and of course, it will maintain transparency.